Oh man, another highly requested topic today is about billing and coding. This can be super confusing, especially as a brand new nurse practitioner. We don't really talk about it that much in school, and you kind of have to learn it on the job. So in this video, I'm going to be breaking it down, talking specifically, zeroing in on office visits in primary care. If you're new here, I'm Liz Rohr from Real World NP, and you're watching NP Practice Made Simple, the weekly videos to help save you time, frustration, and help you learn faster so you can take the best care of your patients. So a couple disclaimers before I start. Number one, I'm talking about primary care only. I'm not savvy enough to talk about skilled nursing facility, long-term acute care, or hospital-based medicine because that's just not my expertise. So if that's you, you might want to skip this one. Disclaimer number two is that I'm not a billing and coding expert. I'm a self-taught nurse practitioner who has also gotten guidance from billing and coding. I'm using the CMS evaluation and management guidelines, which I'm going to be linking down below, but that's what everybody uses to kind of justify their billing codes. The third thing is that there are many different kinds of types of visits you can bill for in primary care. So number one, what I'm going to be covering today, because it applies to the vast majority of visits you're going to see in primary care, is office visits. And you might say they're all office visits. However, there's different billing for preventative health care, meaning a physical, a well-child check. There's definitely a different one for a Medicare physical. And then procedures are a little bit different as well. So because the vast majority is office visits, I'm going to be focusing just on that today. However, I'm also planning on doing a preventative video if that is of interest to you, and how to maximally accurately code your billing. I'm not talking about manipulating or gaming the system to get like the most of your money. I'm really talking about accuracy, because people tend to want to underbill or overbill, and really it's just important to get the facts and document and bill appropriately. So I'm going to share my screen with you to make this really easy, but a couple of notes first. Number one, there's a cheat sheet down below this video with a couple of tables, examples, and references. And really the absolute easiest way, absolutely go through and watch and listen to this. However, the easiest way to get a handle on this yourself is to practice. And it doesn't take that much time. It takes a little bit of time, but it doesn't take that much time of going through some examples, figuring out what the billing code would be based on that. And then once you have that muscle memory of having done that a couple of times, it'll be way easy. Three things. Number one, when it comes to billing at the end of your visit and you've got your note done, you're going to think about the charge. The first thing you're going to think about is your level of medical decision making. And basically what that means is how much of your brain are you using? So is this a very simple allergic rhinitis that you can treat with over-the-counter medication versus is this an acutely decompensating person with CHF in the clinic that you're thinking about sending to the ER? Those are very different levels. Just stick with me, I'm going to break this down. You kind of stratify it based on that medical decision making is what it's referred to as, and it's a level 1 to 5. So level 1 is the least acuity, so somebody, for example, who has allergic rhinitis and you prescribe them Flonase, which is available over the counter, versus a level 4 or 5 with those more complex patients. So medical decision making is your very first thing. Number two, what you want to think about is how do you support it with your documentation. Start with the medical decision making, and then just make sure that your number that you're submitting, that you've chosen for your medical decision making, is backed up with the appropriate amount of documentation, which you'll see in just a second. Stick with me. And number three, when it comes to office visits, there's two other branch points. One is are they new or are they an established patient in your practice? So if they've never been seen there before, they're a new patient, or if it's been greater than 3 years, versus if they've been seen in the last, less than 3 years, then they're typically an established patient. And the reason that's important is because new patients typically reimburse more money because there's typically more work involved, but that also means that you have to document more to kind of support your case of why you get to charge for that higher amount of money. So let me jump in and I'll share my screen with you. Okay, so just a quick recap. So number one, you're going to start with your medical decision making when it comes to billing your E&M codes, which is again, those level 1 to 5. You're going to think about if they're new or if they're established, and then you're going to just make sure that all of your documentation is there to support it. And it actually is you're going to find that it's a lot less than what you think it is. So I'm just going to go over starting with established because those are the most common codes you're going to see. And so level 1 is typically a nursing visit. The prefix is always 992, and then the last two numbers are the things that are different. So 11 is a nursing visit. 99212 is a minor problem, for example, allergic rhinitis, things like that. And I actually have a whole table. If you haven't downloaded the cheat sheet already, it has the table of risk that is in the CMS guidelines. It talks about all the different examples, not all of them, but it's not comprehensive, but you can kind of extrapolate based on what the examples that they gave you are. And then also the different tables that I have put together based on the guidelines, and then the data that's been published after, which I'll show you in a second on this presentation. But definitely download that if you haven't already. So 99213, the level 3 is, for an example, is an acute illness like a cystitis or one stable chronic illness. And then level 4 on 99214 is two or more chronic illnesses, or if a chronic illness is worsening, or for example, if you have an undiagnosed new problem with an uncertain prognosis like abdominal pain. And then, I'm sorry, that should say 99215. That's a severe exacerbation. And I've actually never coded for a level 5 in primary care. And you'll see when you look at the table of risk, looking at the different, assessing the different options, the different examples that are there. Typically, those patients need to be cared for in the ER or the hospital setting. And I felt conflicted over the years about, do you code for that a level 5 because you're sending them out, or do you code them only a level 4 because you're not doing that level 5 intervention because you're sending them out for that? So definitely get clarity in your own practice with your supervisor or with billing and coding. I've never really gotten any feedback about my incorrect level 5. So I just don't have any, I guess. So those are the established codes, and E&M codes are basically the same for new in terms of your medical decision making, which again I keep talking about because that's the most important thing. It just requires more documentation. So it just ends in 01 instead of 11. So 99201, 99202, 203, 204, and then 205. So again, when you're looking at your billing codes, you're deciding which one to pick, you're going to start with your medical decision making. And I'm actually going to toggle over to the cheat sheet that that I made. Well, first of all, So first of all, I'm going to toggle, we'll start with the one that I made. So at the very top, what you're going to do is, again, this is talking about medical decision making. And this is literally, when I talk about practicing, this is exactly what you can do on a sample of your own notes or somebody else's note, and check off the boxes to see if they actually qualify for the billing code that they chose. So if somebody documented a 4, you can go through and literally check the boxes off of this whole cheat sheet for each note that we're talking about or that you're looking at, and you can kind of see, did they meet the criteria, right? Just for fun. Again, it takes a little bit of time, but even if you just did 3 notes, you would feel, I think, a lot better about it. So again, step 1 is looking at your level of risk. And so this table here is not part of the guidelines, but it was made after to help guide clinicians. And I saw it cited from a variety of sources in different ways, and I kind of put it together in this way that was helpful. I had a resource in the past that had this already made out, and I can't seem to find it, but this is based on putting all the data together into this table. So anyway, this is the guidance that is developed after the guidelines came out. So what you're looking at, and actually going back to the presentation, the 3 things here are risk, problem points, and then data points. I'm sorry, it's not letting me do that. So what we're looking at here is your risk, the level of risk of the problem, the data points involved, and then the problem points. And so underneath here are the problem points and the data reviewed points. So let's just start with the table of risk. So this is literally out of the guidelines. This is the table of risk from the CMS guidelines. And it typically matches up this way. It's not written on here, but you could print this out, and then I have this printed out at my desk, but you could print it out and write next to it. Typically, level of risk minimal is a level 2. Low risk is a level 3. Moderate is a level 4. And then high risk is a level 5. And what's on this table is you're looking at the different problem examples. The middle column is diagnostic procedures ordered, and then management options selected. And you don't necessarily have to have 1, 2, and 3 for them to qualify for minimal, but if it's kind of helping inform you make your decision. So what testing are you doing for this problem? What interventions are you doing for this problem? So if your intervention for your problem is gargles and rest, likely it's a minimal risk problem, right? If it doesn't say it here, insect bite, tinea corporis, things like that. So tinea is interesting because you can prescribe for it, but I believe it's because it's over the counter, like clotrimazole is, the treatment. That's why it's considered like a minimal risk one. But anyway, like I said, you don't have to have all of these, but you're looking at the reason to print out this table is that you can look at the examples here of the different presenting problems to help guide you in that medical decision making. So if we kind of toggle back here to this cheat sheet, again, you're literally going to fill this out. So what is your level of risk for your problem? Is it minimal, low, or moderate? Again, because the high risk ones are typically you're sending them to the ER. Because if we scroll down to the high risk ones, they're having elective major surgeries, emergency major surgeries, things like that, which you're not doing in primary care. But you can kind of select here. So I'm going to slow down for a second. So again, level 2, self-limited or minor problems like a cold, upper respiratory infection, that's just supportive care, insect bite, things like that. A level 3, a low risk, is 2 or more self-limited or minor problems. So if you had a couple of those, or if you had one stable chronic illness, well-controlled hypertension, not insulin-controlled diabetes, patients who have BPH, or one acute illness like a cystitis or allergic rhinitis, things like that. Actually, I thought that was under minimal, but I guess that's considered a low risk one. So you couldn't bill for a 3 if you had allergic rhinitis. Moderate, those are 1 or more chronic illnesses with a mild exacerbation. 2 or more stable chronic illnesses like diabetes and hypertension, things like that, or an undiagnosed new problem with an uncertain prognosis. And again, like I said, the vast majority of the time, moderate is going to be a level 4, but it depends on this further calculation. So let's just go back for a second. So you're looking at the end of your note, you're looking at the billing code, you're looking at the level of risk, which you're going to look at that table of risk from the CMS guidelines. And then you're going to scroll down to these tables and then add them up. And the important point here is that you need 2 out of 3 of these. You don't necessarily need all 3 of those to qualify, but let's just go down. So problem points, what are the points that are associated with that? Again, these are not in the guidelines, but this is guidance that was developed after the guidelines. And so, for example, if you have somebody with a cystitis, you have an option of a self-limited or minor problem, established problem that's stable or improving, an established problem that's worsening, or a new problem, but you don't have any other workup planned, or a new problem with additional workup planned, right? That kind of makes sense in terms of your clinical decision making, right? So for an example, if you have somebody with cystitis, you have a new problem, but no further workup is planned. Like you just did, maybe you did a urinalysis, right? But you're not necessarily going to send out a culture because you can treat them empirically. And so what you're going to do is go back to their table of risk. I know from looking at this 1,000 times that cystitis is qualified under the low risk level, and that's a level 3. She doesn't have systemic symptoms, for example, if we're talking about a woman who comes in with dysuria. So we're in a low risk, and we're looking at the problem points. So it's a new problem with no additional workup, so it's a level 3. So it could technically fall into a level 4, but your risk needs to be moderate. So it has enough points to qualify for a level 3, but not enough to qualify for a level 4, if that makes sense. And then your data reviewed points, we actually don't need to do this for that particular example because, again, it's only 2 out of 3. But you could look at the data reviewed points. So did you order any lab tests? I guess if you sent, urinalysis would count. X-ray, EKG, did you discuss the tests with a performing physician? If you were talking about a specialist, ordered some labs and then you get on the phone and talk to them. Or if you independently reviewed an X-ray or an EKG tracing, if you went through old records, things like that, review and summation, you get like different data points involved there. And you can have multiples, right? Which will kind of add you up to that 3 if you're looking at a level 4 type of visit. So again, step 1, you're looking at medical decision making. You're literally going to these points, looking at this table of risk and filling it out. And do they qualify or not? And so let's go back to the presentation here. So again, those 3 things: risk, number of problem points, and then the data points, and then your documentation. And I'm gonna try not to bore you to death because I clearly am excited about this, but you just want the nuts and bolts so you can do it right. So I'm gonna try and be as brief as possible. But basically, these are the elements that your note needs to have. And the amount that you document is what differentiates levels 2 through 5 or 1 through 5. But again, we're not really doing level 1s. Everyone needs a chief complaint, regardless of level. Number 2, everyone needs an HPI. However, the difference is how much you document. Number 3, past medical history or surgical history, family history, and social history has a star next to it because actually only the ones that need that are new visits are a little bit different, but established visits for a 4 and above are the only ones that actually require that to qualify. ROS, I have that everybody should have that. I mean, typically if you're doing a note, you're going to include some kind of ROS, right? But technically, if you have a level 2 problem, you actually don't need to document anything under the ROS. And then for the levels 3 and 4, this is for established patients, you just need to document a certain amount, and it's actually less than you would expect. And then 5 is a physical exam, and every level of visit that you see has to have a physical exam. So I'm just going to toggle back over to the cheat sheet because I think it's easier to look at this way first. So on the second page is the documentation required for each level. So like I said, these are all of the elements. I'm not going to talk about time today because there's something else I'm just going to save that for another time. But again, you start with your medical decision making. If it's straightforward, low complexity, moderate complexity, or minimal is another way to say straightforward. And these are for established visits, again, 99212. And actually, I'll update that before I send it out to you. That it'll say established and new for clarity. But basically, it's a lot less documentation than you think. So if you have a 99212, if you have somebody with tinea corporis, nothing else, all you need to do is 1 to 3 elements in the history. You don't need an ROS. You don't have to document the surgical, family, social history. And then the physical exam comes down to either body systems or elements. And I'm not going to bore you with the details, but there's different guidelines from 97 and 90, 95 and 97. Actually, I didn't mention that these are all based off of recommendations from 1995 and 1997. So if you're worried about things being up to date, they haven't really been updated in a very long time. But there are 2 options. You can either talk about elements, which is, regular rate in terms of cardiovascular exam, regular rate and rhythm, lungs clear to auscultation, and the respiratory. Those are 2 different elements. Like those are 2 distinct elements versus the body system is cardiovascular, respiratory, et cetera, if that makes sense. And so that's a level 2. A level 3, 1 to 3 elements, and just hold that thought. I'm going to show you what the elements are. ROS, you really only need to do 1 system, which is pertinent to the problem that's in front of you. Or if you're talking about hypertension follow-up, you could do cardiovascular, things like that. You don't need a past surgical, family history, social history, although most likely you're documenting this and it's typically recommended, right? You kind of are curious about their smoking status if you're talking about hypertension, right? But in terms of the bare minimum of what you need to have, that's what it is. And so again, for level 3, for those moderate risk ones, you can either do the elements, those bullet points within each of the body systems, like throughout the body systems, versus do you want to do 2 organ systems that are relevant, right? So if we were talking about dysuria, you want to talk about the GU organ system. And then you probably want to talk about GI too, at least, right? You want to talk about the systems that are relevant to that complaint. And then again, your medical decision making, we've already determined that, and you just want to make sure that once you decide that medical decision making, you can go back and make sure you have all of the things. The takeaway here is that I'm going to toggle back and I'll show you what the HPI elements are. But basically, in summation, it's kind of like your old cart, right? Your onset, location, duration. Each of those things are 1 element, which is insane to me when I learned this, because you only have to say onset, location, duration, and that's 3 elements, and that's all you need for level 3 for 1 acute complaint, right? And then 4 or more, so onset, location, duration, and have they taken any meds? That's 4. 4 or more qualifies you for basically anything else. And then the ROS for the level 4, it's 2 to 9 systems, again, cardiovascular and respiratory, right? Or depending on the problem of what it is, choosing those. And it doesn't necessarily specify that. This is the major kicker here. And this is when I talk about using examples and making sure that your documentation supports it. This is the most common thing that I see in, number 1, my own documentation, but also looking at others. If you're doing like an audit or something, is that if you charge for a 4 and you have all this complex medical decision making, if you haven't documented on the family history, that's what's going to trip you up and you're not going to qualify, right? So that's like, I think that's my takeaway. My personal hack here, and I don't know if this is correct, so maybe check with your billing department before you do this, but I typically chart as if every visit is a 4. I mean, within reason, right? But I always document some sort of social history that's pertinent, right? And smoking is always pertinent to whatever is going on, right? And then physical exam, I'm so sorry, I forgot. I'll update this when you have it in front of you, but it should be, say, 5 to 7 organ systems or body systems. And those are the typical ones that we're talking about, right? General, cardiovascular, respiratory, GI, GU, et cetera, et cetera. So you can either do 12 bullet points or you can do that 5 to 7 body systems. And those are the patients that have moderate complexity. And then just briefly, and again, I'll update this before I send it out to you. This is the new patients. So the medical decision making, as you'll see,
and this doesn't correlate because this is 2. So look at this column and then look at this column. But the 3 and the 3, sorry, I shouldn't have done it that way. But you'll see that the complexity is the same. Low and low, moderate and moderate, and then 5 is high and high. So the medical decision making is the same. However, if you look at the 3, there's a lot more to document. So basically, if you have a new visit, you just want to toggle all the way over to the highest level of documentation, to be honest. So if you have a level 3 and it's a low complexity, most likely you're going to have a moderate complexity, right? Depending on where you're practicing. But if you have somebody with uncontrolled diabetes and hypertension, that could probably qualify for a moderate. And so you want to make sure that there's at least 4 elements in the HPI, again, onset, location, duration, things like that. ROS, you actually want to do 10 body systems. You definitely want to address the family history, and it depends. I saw conflicting resources about, do you want to address all of them? Social history, past surgical history, family history. I typically do for my new patients, so I kind of recommend doing that. But I think what I read was either all 3 of those areas need to be addressed or just one. And the physical exam says 18 elements. And again, those are bullet points. I couldn't really find a resource that said how many body systems. Probably that would qualify in 5 to 7 body systems in terms of, again, like regular rate and rhythm, lungs clear to auscultation, et cetera, et cetera. And then just kind of, basically you're just kind of moving it one forward. And so you're kind of documenting more than you quote need to for those new patients. So just toggling quickly back to that presentation. So the elements, I'm going to go through this quickly and you can kind of just look at this. Again, location is one element. Quality, aching is one element. And most likely if you're, most clinicians are going to, especially if you're brand new, you're probably documenting on all of those things. And that makes for a great history, right? But at the very bare minimum, you have to have at least 3 for most visits. And again, I kind of already mentioned this. ROS is based on the body systems. And again, these are the ones that you're familiar with, right? So GU, GI, hematologic, musculoskeletal. Again, you just want to choose a certain number of systems depending on how high of a billing code you're choosing, and you can go refer back to that cheat sheet. And then either, again, elements or the organ systems. So I've listed here the organ systems, and again, it's about 5 to 7 for that 4 and above, and up to, you could probably even just do up to 10, or you can choose it based on the elements of the bullet points. Well-developed, well-nourished, lungs clear to auscultation, regular rate and rhythm, abdomen soft, like those are all elements. Yeah, and then a couple of patient examples. I'll just do 2 here. 33-year-old female with dysuria. So this is basically how you would use this. Is again, you're scrolling back to the top of the office visit. You're doing medical decision making first. So we have a 33-year-old female with dysuria who you're diagnosing with a UTI and you're prescribing some antibiotics. So you're going to go to the table of risk first. This is the most important first step. And then you're going to look again. I keep giving this example. I'm sorry I copped out and I gave somebody this example, but somebody with an acute, uncomplicated illness or injury. So she didn't have fever, chills. She didn't have signs of pyelonephritis, because again, that could actually bump her up into the next category. Where is it? Systemic symptoms, like i.e. pyelonephritis, things like that. That could bump her up to that level. But she just has cystitis, so we're going to do a low level. And so now you've assessed your risk. She is a low level, so she could qualify for a 3. However, you want to make sure she at least qualifies for the data points or the problem points. So we're going to scroll down. She has a new problem with no further workup planned. So she is a level 3, so she definitely meets criteria there. And we don't even have to look at the data points, but we could. Did we order some blood tests? Maybe we did. I don't know. I don't think we did. We're gonna leave that alone. So that's it. So you would definitely bill for at least a level 3, and then the documentation you need to do. Let's scroll down to the next one, because again, first one is medical decision making, and then second is to make sure you documented enough. So so for level 3, low complexity, 3 elements: onset, location, duration. Started yesterday. I guess location, dysuria, right? Urethral burning. And is it coming and going? Is it there all the time, et cetera, et cetera. And then one body system, you do the GU, ROS. That's all you need. You don't have to talk about the family history, social history. Again, I recommend doing this. Use your clinical judgment and do the best nurse practitioner care. However, this is why I kind of tell some new nurse practitioners that I work with, or that I've worked with in the past also, that you don't have to chart as much as you're charting. However, just, do your due diligent job. But yeah, so 6 elements or 2 organ systems. So you could do, GU and GI. Those are your physical exams or whatever is pertinent, right? You won't necessarily do a GU exam on somebody who has a dysuria, but abdomen and cardiovascular or something, respiratory. I typically do heart and lungs for most visits, and that's it. And those are all the things that you need to document because it's an established, and these are all established patients. And so, just one more example. Again, I don't want to bore you to death. So this is a 56-year-old man with uncontrolled diabetes and hypertension. And so we're going to first scroll back up to the beginning of this, and then we're going to look at the risk. So we're going to go over to that table of risk, and there's 2 problems with uncontrolled diabetes and hypertension. And so I already know we're going into moderate, right? Because we're going to 1 or more chronic illnesses with a mild exacerbation. So this is a moderate level 4. And so because this only says 1 or more chronic illnesses, I guess it says or more, but if it was only 1 chronic illness, you want to look at the next category, like would this qualify for a 5? 1 or more chronic illnesses with a severe exacerbation. So I would not qualify kind of like mildly worsened hypertension and diabetes as being severe. Again, you might want to get clarity from your supervisor or from billing to make sure that you are, like if your A1C is 13 and your blood sugar or blood pressure is like 210 over 100, maybe that's a little bit different. You might bill for a 5. I'm not sure. Definitely clarify on that. So anyway, so that's a moderate complexity. So it could qualify for a 4. So let's go over to the problem points and the data reviewed. So problem points. So we've got established problem worsening. We definitely get 2 points there. And I think my lingering question here is that I believe this qualifies for a 4 because it is only giving it a 2 because it's an established problem, but it's actually 2 problems that are worsened. So I think that you could actually bump it up from there, if that makes sense. So that could be a 3. And then data reviewed, did you order any blood tests that day? Did you review their past records? And a pearl here, I don't remember if I mentioned this already, it's not enough to say reviewed labs. I mean, you can either input the labs themselves, or you can kind of say things like white blood cell was high, chest x-ray was unremarkable, like those are considered acceptable. But you kind of want to say, especially if you're getting old records, like you want to talk about like why and what that means and the ramifications of that, not just the physical act of, oh, I requested their records, which I didn't really understand at first, but that's in the guidelines themselves. So that's pretty much it.
Did you like this video? If so, hit like and subscribe and share with your NP friends so together we can reach as many new nurse practitioners as possible to help make their first years a little bit easier. And if you haven't grabbed the cheat sheet from this video down below, definitely do that. You'll also get these videos sent straight to your inbox every week with notes from me, patient stories, and bonus content I really just don't share anywhere else. Thank you so much for watching. Hang in there, and I'll see you soon.